Hernandez from DCRI, the acute study of clinical effectiveness of Neseritide in the compensated heart failure trial, the ASCEND-HF. Dr. Hernandez.
Thank you to the chairs and the distinguished panel. Ladies and gentlemen, it's my pleasure to present the ASCEND-HF results on behalf of the committees, investigators, and study coordinators. Here are my disclosures. The trial was sponsored by SciOS, a research funding from Johnson & Johnson, as well as honorarium from Amgen and Corthera. We've already seen this slide, but just to note that this was a trial that was run by an independent executive committee that was responsible for the overall conduct of the trial. Acute heart failure is a major health problem responsible for several million hospitalizations worldwide each year. Standard therapy has not changed since the 1970s and includes diuretics and variable use of vasodilators or inotropes. In 2001, Neseritide was approved by the FDA to reduce wedge pressure and improve dyspnea based on efficacy at 3 hours. However, in 2005, two meta-analyses raised concerns regarding the risk of mortality and renal injury. Subsequently, an independent panel was convened by SciOS and recommended that a clinical trial be conducted to definitively answer the question of Neseritide's safety and efficacy. The results of this panel was ASCEND-HF. There are several guiding principles regarding the design of ASCEND, and this includes an independent framework, a pragmatic trial model that was focused with efficient study design, streamlined procedures, and simple follow-up to integrate with usual clinical care. Permissive enrollment criteria for a broad population of acute heart failure was allowed, meaningful outcomes, as well as standard of care per local practice. There are two co-primary objectives. The first co-primary objective was whether Neseritide reduced the rate of heart failure rehospitalization or all-cause mortality through day 30. The second co-primary objective was to evaluate dyspnea at 6 or 24 hours using a 7-point Likert scale, shown here with responses ranging from markedly better to markedly worse. The secondary endpoints included overall well-being at 6 and 24 hours, persistent or worsening heart failure and all-cause mortality from randomization to discharge, numbers of days alive and outside the hospital, cardiovascular rehospitalization, and cardiovascular mortality. The safety endpoints included all-cause mortality, worsening renal function defined by a 25% decrease in estimated GFR at any time from study drug initiation through day 30, and hypotension as reported by an investigator. This shows the study design and drug procedures. Patients with acute heart failure less than 24 hours from IV treatment were randomized to Neseritide or placebo in a double-blind fashion. IV bolus was given per the investigator. It was followed by continuous IV infusion for up to 7 days. Usual care was per the investigators and included diuretics and/or other therapies as needed. The duration of treatment was per the investigator based on clinical improvement. The inclusion criteria listed here: patients had to be permanently hospitalized for acute heart failure less than 24 hours from IV treatment, have dyspnea at rest or with minimal activity, 1 clinical sign, and 1 objective measure. The key exclusion criteria shown here: hypotension at baseline with systolic blood pressure less than 100, or less than 110 with an IV vasodilator. Other exclusion criteria were significant lung disease, acute coronary syndrome, severe anemia or bleeding, treatment with levosimendan or Melrinone, unstable doses of IV medication within 3 hours. For our primary study population, it was a modified intention to treat based on receiving study drug. Because we had two co-primary endpoints, the alpha was split. The composite significance level was at the 0.05 significance level, and the dyspnea was at the 0.005 level. Furthermore, for dyspnea to be significant, both the 6 and 24-hour assessment p-values had to be less than or equal to 0.005, or either one had to have a p-value less than or equal to 0.0025. The sample size was determined based on the composite endpoint, and we estimated 89% power with 7,000 patients. This shows the enrollment. Over 7,000 patients were enrolled in 30 countries and nearly 400 sites. North America had the largest enrollment with 45%. Among the patients randomized, 7,141, approximately 98% received study drug and serve as our primary analysis population. There are no significant differences between the placebo and the Neseritide group for not receiving study drug. This shows our baseline characteristics And you can see here between the placebo and the serotype group, it was well balanced based on age, demographics, vital signs, and medical history. The number of patients who had an EF less than 40% was approximately 80%. BNP or pro-BNP values were elevated in both groups. Pre-randomization treatment included loop diuretics in approximately 95%, ionotropes in 4%, and vasodilators in 15%. This shows our co-primary outcome of 30-day all-cause mortality or heart failure hospitalization. In the placebo group, the event occurred in 10.1%, and in the serotype group, it occurred 9.4%, for a p-value of 0.31. When we look at time to event analysis, the hazard ratio is 0.93, with confidence intervals overlapping 1. This shows subgroups for the 30-day death heart failure readmission endpoint, and here we're showing the risk difference. And to the left of the line favors serotype, and to the right of the line favors placebo. As you can see here, all the results are consistent with the overall population, with the exception of low blood pressure. Here are the other subgroups, and again, you can see here the confidence intervals overlap 0 as well. This shows the other co-primary endpoint of 6 and 24-hour dyspnea. For illustrative purposes, we have a line here demarcating the marked better or moderate better response. At 6 hours, this occurred at 42%, and for the serotype is 44%. At 24 hours, the placebo group improved to 66% for the marked and moderate response status, and for the serotype, it occurred at 68%. The p-value of 0.03 and 0.007 did not meet our pre-specified criteria for significance. Here show again subgroups for the dyspnea endpoint. We're showing the odds for marked or moderate improvement, and to the right of the line is favors the serotype, and to the left of the line favors placebo. And as you can see here for the subgroups of blood pressure, renal function, EF, coronary disease, diabetes, it's all consistent with the overall population. Here are additional subgroups based on the background therapies. In terms of ionotropes, vasodilators, and diuretics, and medication bolus, and time from hospitalization to randomization. In general, these are consistent with the overall results, although there are a couple of subgroups that do stand out. One is the earlier time from hospitalization to randomization, in general favors the serotype, and also the group without diuretics. Here shows the secondary endpoints. So for persistent or worsening heart failure, all-cause mortality through discharge, days alive and outside the hospital through day 30, and cardiovascular death or cardiovascular hospitalization through day 30. These are non-significant between the placebo and the serotype group. Regarding the well-being endpoints, again, between the placebo and the serotype group, there are no significant differences based on pre-specified criteria. Regarding renal safety, our safety endpoint occurred in the placebo group at 29.5% and the serotype group 31.4% for a p-value of 0.11. When we examine the end of treatment creatinine level based on cumulative distribution plot, the placebo and the serotype group overlap. Similarly, for the discharge at day 10 creatinine level based on cumulative distribution plot, you can see here the placebo and the serotype group overlap. Hypotension did occur at a higher rate for the serotype compared to placebo, with any hypotension occurring placebo at 15% and the serotype 26%. Asymptomatic and symptomatic were also significantly different, with higher rates for the serotype. Because of the prior meta-analysis raising the questions regarding 30-day mortality, we chose to update the meta-analysis. Here you can see the latest studies before ASCEND with the odds ratio for 30-day mortality at 1.3. And when we add ASCEND, the odds ratio is 1.0. In conclusion, the serotype did not reduce the rate of recurrent heart failure hospitalization or death at 30 days. The serotype reduced dyspnea to a modest degree, consistent with previous findings, but did not meet pre-specified protocol criteria for significance at 6 and 24 hours. The serotype did not affect 30-day all-cause mortality, nor did it worsen renal function, as had been suggested by prior meta-analysis of smaller studies. There are several implications from the ASCEND trial. The serotype can now be considered a safe therapy for patients with acute heart failure. Further analysis of ASCEND is likely to permit better understanding of acute heart failure and patient profiles that may potentially benefit from the serotype. Our results from this large randomized trial emphasize both the challenges of making therapeutic decisions on inadequate evidence as well as the urgent need for large, well-conducted trials capable of informing clinical practice. I want to thank our steering committee and thank you for your attention.